Good morning, everyone. I'd like to welcome all of you to the exhibit hall, Rhythm Theater number 2, for an event where we'll discuss the CardioFocus endoscopic ablation system. The title of this symposium is Visualize Rapid PVI, Fast, Flexible, and Contiguous PVI with the HearLight X3 endoscopic ablation system. I'll ask that you hold your questions until the end, at which time we'll have a Q&A. The two ways to submit a question will be either through the app or by going to the website, which will be displayed /BRT15. Our first talk will be by Dr. Shiro Nakahara, entitled Discrete Antral Lesions from Pulmonary Vein Isolation Using the HearLight Endoscopic Ablation System. He comes to us from the Department of Cardiology in Dokyo Medical University, Saitama Medical Center. Please go ahead. Please bear with us as we work on getting the audio. We're going to have a programming change while you guys fix the audio. We'll let Dr. Huang, my colleague and friend, present fire, ice, and light comparison of HearLight laser balloon system versus other energy sources for PVI. Dr. Huang is at Rush University Medical Center in Chicago.
Thanks so much. Now there'll be a little transition to get the slides up. That's okay?
That's the third presentation.
Do you mind if I use this? So how many in the audience have experience with the laser balloon in practice? Okay. And then how many predominantly use radiofrequency ablation for PVI? And what about cryoballoon ablation? Okay. Other or experimental? Only maze? Just kidding. All right. Okay. So I just wanted to apologize for the title, but it did seem appropriate. Essentially this presentation is sort of an expansion of a poster that we presented yesterday in the session. There's only so much that you can do during a poster session, and the data is still based on the analysis, though, that we did at that time. These are my disclosures. Okay. So as we all know, broadening of recommendations for catheter ablation have led to a tremendous growth in the number of AFib ablations performed per year, making it the fastest growing procedure in the field of EP. For various reasons, though, pulmonary vein isolation remains the cornerstone approach, especially for first-time ablation procedures. While PVIs become more ubiquitous in practice, procedure times have improved, and you could argue that safety has improved. A limitation of the adoption or appeal of PVI still remains the fact that clinical efficacy diminishes over time, especially beyond 1 or 2 years without a drug. Further, when patients do undergo redo ablation, about 94% of patients, this is based on a paper, sorry I don't have the reference there, have at least one pulmonary vein that is reconnected at the time of a redo procedure. So some of the challenges still in our field, which may not necessarily be an area of focus as much right now, is the delivery of durable transmural lesions and also addressing pulmonary vein anatomy. Much has evolved since catheter ablation first started mimicking the maze procedure, actually, over 2 decades ago. As we know, radiofrequency ablation, is the gold standard for PVI. It's been around. According to a Medicare registry, of case data from 2015 to 2017, 70% of ablations were performed with RF versus 23.7% with the cryoballoon over the same period of time. In addition to being the gold standard, the RF catheter is versatile or facile, and you have control of your lesion set and the size of the lesion set. You can do a WACA if needed for a persistent patient, or go ostial. Advancements for RF include, obviously, the addition of irrigated catheters and contact force, integration of multi-parametric lesion markers, and a strategy potentially better of high power, short duration. Disadvantages of RF are, the learning curve, catheter stability, is what I'm referring to, and the propensity for atrial flutter or left-sided tachycardias, particularly in persistent patients. Cryoballoon was an advancement. It did lower the learning curve according to, the trials. There were shorter procedure times potentially in the trials, and it offered, with the balloon, one-shot ability. Some disadvantages to the technology is higher fluoroscopy, though, relative to RF, the need for contrast, which could be detrimental to patients with CKD, and challenges due to pulmonary vein anatomy or pulmonary vein mismatch, meaning that some pulmonary veins may be elliptical or they may be larger, and the established cryo users know what I'm talking about. So, you'll hear a lot about the laser balloon during the talks today, and I was assuming I was going third, so I'm just going to give a brief one-slide explanation of some of the differences between the two. I apologize, I don't have a full-scale description, of the system itself. So, on the top right, you have illustrations of something called thermographs, and so on the bar on the right, we don't have the scale, and this is purely illustrative. The lower temperature would be the dark blue, whatever that scale is or the range is. White would theoretically probably be representative of 100 degrees, okay? And so, the laser balloon, uses a light essentially with the optical area of heating actually being well within the tissue. And, there are some videos out there actually of infrared thermography videos comparing RF and the laser balloon. And the core of the heating is actually within the tissue itself. And what's interesting is that the endothelium, perhaps due to cooling, perhaps due to the location, ends up being preserved after a laser ablation. And so if you bring these patients back, you look at the tissue, which you can see with an endoscopic view, the tissue tends to look normal, actually. And you can see on the necropsy photo on the right this continuous lesion. And someone will talk about the differences between the X3 and the point-by-point method. And that picture is actually a point-by-point ablation lesion set with the laser balloon. And the key is, how does this happen? With the balloon inflating there, it essentially locks into the tissue, and the balloon is in sort of the same contact level as a catheter, and you have a lot of stability. So you can actually stitch or overlap your lesions to reduce the gaps. And, that image there, seeing is believing, is a testament to that. Whereas with an RF catheter on the right, you have resistive heating, and then there's a drop-off in terms of your energy field with distance, but it gets quite hot at the surface. And so obviously the endothelium will be disrupted. There's a lot of heating there. With an irrigated catheter, the core of your heating is lower, which helps, and you're less likely to get char. But most of your heating is conductive, which is probably fine in the atrium where the tissue is not as thick as the ventricle. But keep in mind, your catheter can move. You've seen it with the electrograms changing, or your catheter can be stable, but the heart can move underneath your catheter. Depending on the location, it may be easier, more hostile to get a stable lesion. But if you want to do a WACA, then you're dealing with thicker tissue, right? And it's harder to be transmural. Cryothermal energy, is completely different. In this energy form, you rely on a drop in temperature, and the energy effect is wide and deep. It goes to extracardiac tissue, which is one of the limitations. But remember that you have to get cold enough, and it's still subendocardial, the injury, the majority of it, right? And so although you're acutely injuring tissue, it may not necessarily lead to a transmural lesion. And this is an example from a CERC paper, showing multiple lesion sets, multiple bonus freezes, with the cryoballoon. And although the vein acutely isolated, likely, because if you look in the literature, the isolation rates are near 100%, you can see there's a very thin rim of tissue on the bottom and a gap. And you'll notice that with the cryo lesions, we looked at this in a paper, the gaps tend to be segments, rather than a small area. So if you touch up with the catheter or the area that has the electrogram, often the areas that come back are the surrounding areas, because that tissue is not cooling due to the balloon itself being in contact. It's cooling because the adjacent tissue is cooling in, and it's not enough to cause irreversible injury. In the middle is a nice shot. I don't think that's a common vein, but you can see kind of the balloon inflates, and it sets you up well to do a WACA lesion set if you want, which is, if you see sort of what's posted on Twitter and online, you'll notice the lesion sets for most of these cases look like WACA lesion sets. And you can kind of have a one-shot approach for both veins. I personally still do the carina because there's some data and there can be epicardial connections. And, I reinforce the ridge and that. But you get, really good visualization. You know what you're doing, and you know what the anatomy is. This is an illustration of the balloon inflating. That was a common. So, the cryoballoon is fixed at a size of up to 28 millimeters. But this laser balloon can get quite large, can nearly, not double the size, but, there are veins that can be up to 4 centimeters in size, and this balloon can easily handle that in one shot. And that's sort of an illustration of the expansion. And then you're able to do a lesion set to the common pulmonary vein. So the balloon is actually, now that many different energy forms are out there, the balloon is, the fact that it can expand is a really big deal, in my opinion. So in terms of head-to-head data for the laser balloon, versus RF and versus the cryoballoon, there is data out there. Now, we'll talk a little bit about, the future versions of the device, but most of the data is actually comparing the first generation, of the laser balloon, and they're smaller observational studies, for the most part. But essentially what the data shows is that the efficacy and safety is equivalent between the technologies in these studies. And keep in mind, these are experienced RF users, experienced cryo users, but this data kind of also incorporates the learning curve of the laser balloon, and it's, meta-analysis, right? So it's an aggregate of observational data for the most part, which is hypothesis generating. And, this is sort of the comparison with the first generation of the balloon, versus these technologies, which were around longer. But it's always good to have evidence. So, and terms of the number of cases, in the U.S. it feels like the laser balloon is something that's newer, but they have well over 12,000 cases that have been performed worldwide. I learned that Japan may have over 80 sites, so I need to update the number of HearLight sites in the world. There are quite a few. But I wanted also to go over, since the registry we're going to talk about is commercial use of it, and so this device was, going back to an article, it was FDA approved in April 2016, and I had the pleasure of working with Dr. Wisner, who was in Germany, and I did a case with him at UIC when I was an attending there, and did a laser balloon case with him, and I believe that was somewhere in like September or October, and it was just really fascinating to do. And I was using RF, using some cryo. I wanted to learn more about it, and so I just kept doing cases, and what's that? Okay. I'm gonna have to skip over just to our data real quickly because of time limitations. So, we did a multi-center prospective registry, comparing the three, and we looked at, as a primary outcome, freedom from atrial arrhythmias with a definition of 30 seconds or longer, with other secondary endpoints, and we excluded exclusion criteria there. There were 4 sites included in this analysis, 7 sites total, which the final analysis will be done later. This is sort of the proportion of what the operators were using in terms of RF and laser and cryo before. This is the breakdown in the RF group by strategy, type of procedure, for all of them in proportion of cases. Give you a second there. The baseline characteristics happened to be matched, probably because of the large number of patients, although there were some differences in the groups in terms of LA diameter and size and creatinine, with the creatinines being lower in the cryo balloon, obviously, group. First pass isolation was lowest in the RF group. And it was high in the cryo and laser group. Procedure times and LA dwell time were similar with the cryo balloon and laser. And fluid time was very low with the laser. So this is the meat of it. So for our primary outcome in the survival analysis, after 6 months, there seemed to be, with this analysis, some difference in terms of the RF group and the laser group. Perhaps driven or due to underpowering, the paroxysmal group was significant. In terms of AFib, there was still a benefit. And in the persistent AF group, this was interesting, is that there was a difference in atrial flutters, versus the two groups, the laser and the other groups. Redo ablation procedures weren't a lot, and this will increase. We'll have more data. And sort of in the combined efficacy outcome, secondary endpoint, there was a difference, although a lot of it probably was driven by antiarrhythmic use being higher in the RF group. Just last slides here. We did a sub-analysis of our RF WACA versus laser wound WACA groups in persistent AFib, and we again saw that signal that there was less atrial flutter or left atrial tax in the laser group. And looking at sort of first pass isolation, if you didn't first pass isolate with RF, you didn't have more ATAC, actually. You had more recurrence of AFib, which is interesting in this analysis. And these are some examples of catheter instability, perhaps why in patients with recurrence, why you'd have ATAC or flutter with RF versus the laser lesion set. You can see there's block along the line. It's clean, but there's a connection anteriorly. And so these are nice examples. So I'm going to wrap it. Thanks so much.
Again, we'll leave questions till the end, and you can submit your questions 2 ways, either on the app or by the website that we mentioned. Our next speaker will be Dr. Atul Bhatia, Chief of Cardiology, Aurora St. Luke's Medical Center in Milwaukee. The title of his talk is Initial Experience Using HearLight X3 acute results and validation using adenosine. Can we cue the slides, please?
Thank you very much. I take this opportunity to thank HRS as also the sponsors for this Rhythm Theater session, CardioFocus, for this opportunity to present here. I have no conflicts of interest disclosed. I'll be talking about adenosine testing after pulmonary isolation procedure, and durable pulmonary vein isolation remains to be the cornerstone of AFib ablations, and recurrent atrial fibrillation is often associated with pulmonary vein reconnection due to recovery of conduction across the PV-LA junction. Provocative adenosine testing post-pulmonary isolation has been used for unmasking dormant pulmonary vein conduction. As we all know that PVI acutely can be achieved in 95% of patients using any of the ablation techniques available today, the RF, be it cryo or laser energy. However, the AFib recurrence rates remain high after single ablation procedure. So it becomes essential to ensure effectiveness and durability of the acute PVI. The biggest challenge is how to confirm whether permanent pulmonary isolation has been achieved and what is the impact of the acute PVI on the future recurrences of atrial fibrillation. To that end, I would discuss the use of adenosine, which has been done for last almost 6 to 7 years. It has been used to unmask the dormant conduction and identify sites of pulmonary reconnection after acute PVI. Any energy source, be it RF, be it cryo, be it laser, balloon, causes cell membrane damage, thereby altering the resting membrane potential to a level below which is the excitability threshold. Adenosine restores the cell membrane excitability by way of hyperpolarization. And obviously, everybody understands that it is mediated through the IK-ADO channels in the PV-LA junction and increases the flow. Adenosine electrophysiological effects also include shortening of the AP duration, action potential duration, in both in LA and PV, but more differential effects on the pulmonary veins rather than left atrium. So if the lesions are incomplete, secondary to acute edema, which is expected, or otherwise are non-contiguous, because be it a catheter instability or you've seen from the previous speaker, the cryo may not be able to get all along, adenosine will restore excitability and unmask dormant conduction. To be sure, this can happen spontaneously as well, as been shown in studies, if there's enough lag time, say about 20 minutes, 30 minutes, 60 minutes after acute PVI. However, complete lesions will render PV non-excitable, period. This is a nice slide showing the pre and post ablation in presence of or absence of dormant conduction. You can very well see that in the presence of dormant conduction, post-ablation, adenosine has been able to re-excite the pulmonary veins as compared to when there was no evidence of any dormant conduction noted after testing, which means adenosine could not hyperpolarize the cell membrane. The various techniques have been used. The one we use the same is use PVI using the standard X3 laser balloon. The pulmonary vein wrapping is performed with a multiple lasso catheter prior to and post pulmonary insulation. We're demonstrating entrance and exit blocks through standard techniques, including every vein is tested separately with lasso in place with at least 12 milligrams of IV adenosine in each vein. There's a waiting period at least of 20 minutes per post-isolation per vein prior to the IV challenge of adenosine. And then obviously high output pacing is also performed from multiple poles with lasso to demonstrate loss of atrial capture, i.e. that the exit block. So what do we know about adenosine? There are studies published over the last 5 years. The high predictive value of adenosine provocation in predicting AF recurrences after PV isolation with the laser balloon compared with RF ablation. In this study, 50 patients with the AF paroxysmal randomized either to RF or to the laser balloon with one-to-one fashion randomization. And the acute PVI connection through adenosine testing was noted to be lower after laser balloon versus RF, 10 versus 30%. The more important thing was that no AFib recurrence is noted in those patients who had a negative adenosine test provocation. Now, this is very intriguing that it almost reaches to be 100% negative predictive value. And only 3 of the 8 positive cases in the laser group had positive adenosine, which means the predictive value positive was 37%. If you compare that to the negative predictive value post-RF group was just 37%. And when you look at a 1-year data from this study, there was significantly less AF recurrences post-laser balloon at 12 months with high negative predictive values, suggesting acute efficacy post-VLGB persistent at 12 months. Another study to look at adenosine was to compare acute reconnection with the laser balloon versus RF, the REDS bonus study. Again, this was randomized to 50 patients each, 1-to-1 randomization. Acute PV isolation was achieved almost comparably in the both groups at 96 to 97%, whether it's RF or whether it is the laser balloon. The pulmonary reconnection rate was still 1/3 in laser balloon versus RF, defined by provocation through adenosine. When I look at a systematic review of adenosine testing after atrial fibrillation or ablation, this was a nice study looking at a lot of data. A meta-analysis of 22 studies to assess the rates of freedom of AF when patients with dominant PV conduction versus patients with no PV conductions demonstrable after ablation. Patients were given IV adenosine, various protocols used from 12 to 18 milligrams versus no adenosine post-PVI, and relative risk was calculated using random effects modeling. In 18 of the studies, about 3,000 patients, the freedom from AF recurrences was significantly lower in those with adenosine-targeted triggered dominant conduction versus no reconnection, 62 and 67%. As also in 7 of the out of the 22 studies involving about 3,000 patients, freedom from recurrent AF was significantly higher in those who were tested with adenosine, which means if adenosine tested showed evidence of dominant conduction, additional RF was given or ablation was done out, and then their freedom was about 67% versus 63%, again encouraging that it could be used. So what is the prevalence and clinical impact of spontaneous and adenosine-induced PV reconnection in contact force versus cryo balloon, the large circa dose study? Again, looking at whether it is the just waiting period versus the adenosine challenge. Again, procedural wait times are important. There is no exact time. Data have been from 20 minutes waiting minimum to up to 60 minutes, with some data suggesting that at 60 minutes, you could even have a higher incidence of spontaneous reconnection. However, most of the studies have used minimum cutoff of 20 minutes waiting period, at least per vein before injecting IV adenosine, which I also follow. So both procedural wait time and pharmacological challenges are tools to unmask dominant conduction. There are 346 patients with PAF and randomized then to either contact force guided RF or cryoablations. And patients underwent provocative testing with adenosine after 20-minute waiting period. All patients received an ILR for AF recurrences. Spontaneous reconnection was observed in about 5.4% patients. It's important to know 5% people had spontaneous reconnection. The results are in front of you. The patient without spontaneous or adenosine-provoked reconnection had better outcomes. However, there was no difference in recurrent AF rates noted between RF and cryo groups in the absence of acute reconnection or spontaneous or provoked. Again, emphasizing the point that acute PV reconnection is associated with significant higher incidence of recurrent atrial tachyarrhythmias in cryoablation groups in patients who had reconnection versus who had no reconnection. So, adenosine-guided pulmonary isolation for treatment of PAF, an international multi-center randomized superiority trial, was published in Lancet way back in 2015 by a group from the advice group. And they found that after acute pulmonary isolation, if dominant conduction was noted post-intravenous adenosine challenge, patients were randomly assigned to additional adenosine-guided ablation to abolish dominant conduction or to no further ablations. If no dominant conduction was revealed, randomly selected patients were included in registry. Patients were allowed to follow for 1 year. The primary outcome was determined to have symptomatic atrial attack after single procedure with intentional retreat analysis. And that's the slide showing that primary outcome, 69% of the 147 patients with additional adenosine-guided ablation were free from symptomatic AT, as compared to just 42% of the patients with no further ablations done in this group in which adenosine-guided ablation was carried out. Important difference of outcome. Secondary outcomes in the same study, freedom from atrial tachycardia was 65%, was 39% was significant also statistically in patients who were randomly assigned to additional adenosine-guided versus no further ablation. Freedom from symptomatic atrial tachyarrhythmias off antiarrhythmic drugs, again important, were significantly greater in patients randomly assigned to additional adenosine-guided ablation versus no further ablation. And freedom from any tachyarrhythmias off antiarrhythmic drugs was also better, close to 60 versus 37% in patients assigned to adenosine targeted group. So our own experience, which is still unpublished, is the interim analysis of 41 patients, but this is all with the X3 balloon. We had 41 patients interim analysis with the majority of patients with predominant fibrillation, 92%, and only about very few patients with persistent fibrillation less than 1 year. 1 out of 33 patients, about 3% were having previous AF ablation, and about 20% patients had additional atrial flutter lines given as well. See, the average procedure times in the first case was 135 minutes, and the shortest time has been about 61 minutes with average time, basically much better as compared to the initial learning curve starting from the first case down to the 41st case now. 1/4 of the procedures done on this X3 laser balloon have been less than 100 minutes. The acute, what we found was the acute isolation rate was 99.4%. High rate of vein first pass isolation, about 98%. The median procedure time has been 117% so far, with the mean fluoroscopy time about 26 minutes. This is encouraging to be defined as a time from venous access to the placement of the HearLight catheter in left atrium, and defined as time from venous access first to the withdrawal of left atrial catheter, last left atrial catheter. To be sure, no mapping attempts per PV were to achieve isolation. All patients were given intravenous adenosine per each vein at 12 milligrams, minimum of 20 minutes waiting per vein, followed by the protocol I outlined of pacing from within the vein mapping catheter demonstrated exit block as well. So acute isolation was obtained at 97.6% of patients with single pass. With rapid mode, the total therapy time to treat a vein was less than equal to 5.6 minutes. So rapid mode is one of the advantages we use for this X3 light balloon, which is equivalent to the HPSD, the high-powered short duration lead, circumferentially given, alongside which you can titrate from 13 to 15 watts based on whether you're in a posterior wall or anterior wall, and you can always substitute some manual lead in addition. These are the interim results at 6 months with the use of antiarrhythmic drug therapy, freedom from atrial fibrillation. Going back to before the final results, non-invasive monitoring was done at 3, 6, 9, and 12 months, with almost 65% of patients, 68% of patients using cardiomobile recordings on a daily basis, and rest were monitored with EKGs on visits. So at 6 months, we had 89% of the patients who had no recurrence of atrial fibrillation or atrial tachyarrhythmias, defined atrial flutter ATAC, with the use of concomitant antiarrhythmic drugs, and 81% without. At 12 months, our freedom from atrial tachyarrhythmias, atrial fibrillation is 76% off antiarrhythmic drug therapy and 84% with antiarrhythmic drug therapy. So the key findings of our initial interim analysis of these patients of 41 cases is that acute pulmonary vein isolation can be achieved with almost 97% patients with the light balloon, with the X3 balloon, and 6-month and 12-month recurrence rates are pretty encouraging without antiarrhythmics at about 76%. Adenosine-guided pulmonary isolation with the X3 light laser balloon is an effective and efficient approach associated with improved long-term outcomes, at least at 12 months, in patients with predominantly pararrhythmic fibrillation. And I would conclude that adenosine challenge is useful to predict acute reconnection and possible additional lesions if needed. Thank you very much for your time.
Thank you, Dr. Bhatia. Again, we'll have questions at the end. Our next speaker is Dr. Pieter Koopman, cardiac electrophysiologist in Jessa Ziekenhuis Hospital in Hasselt, Belgium. I'd like to thank him for joining us today from there to present, and also thank him for showcasing his ability when I went to visit him last year.
So thank you very much for the opportunity to speak at this CardioFocus Symposium. Unfortunately, I could not be present in person because of travel restrictions. So I hope my slides are shared now, because I do not see that. Okay, try again. All right. I hope this is better. Can you all see my first slide, please?
Yes.
Okay, so that's good. So I sent you some foods from Belgium to eat during lunch, because I cannot attend in person. And in the meantime, we'll talk a little about our first experience of the X3 catheter in our center, and we even have some very nice 12 months results to look at. So these are the graphs and the figures that you will see in lots of papers nowadays, where they are comparing RF ablation or comparing cryoablation to laser balloon ablation. And in fact, they are all showing the same effectiveness of 80% of freedom of atrial fibrillation after a follow-up of 1 year. But in clinical practice, myself, I'm not really interested only in effectiveness. I want a procedure to be efficient. The difference is that effectiveness is some form of quality, as is a low burden of adverse events, but we also want a procedure that is easy to perform, that is cheap, and that is fast, so we can treat lots of patients but in a qualitative manner. So I'll try to show you that this laser balloon ablation, as we know it, is at this time one of the most efficient techniques to achieve that. We did our first laser ablation in Belgium in December 2014. That was still the first generation laser, where we put these overlapping segmental lesions all around the pulmonary veins. And we have some very interesting results with that. You see at 1 year follow-up, we have 88% of freedom of atrial fibrillation. It's the same for paroxysmal and persistent AF. And at 12 months, we still have 74% of freedom of AF, almost 80% for paroxysmal, and more than 65% for persistent atrial fibrillation. So with these, if you look at these efficiency bars in this meta-analysis, you see that most of the studies can achieve 60 to 80%, then our results are a little above the average. But interestingly, our 5-year results are still above the average of the 1 year follow-up with laser balloon. So I think this means that the lesions that we put are really durable and are long lasting, and we do not see many patients with recurring AF after 1 year. In the meantime, lots of things have changed, and so since May 2019, we are performing ablations with the 3rd generation laser balloon that is called X3. The 2 improvements that occurred is, first of all, we had a more compliant balloon, which was called Excalibur, and with this balloon we are achieving a nice 360-degree occlusion for almost every pulmonary vein ostium. And with the X3, we also have this motor in the handle of the device that makes the rotation automatically, so we can put continuous circumferential lesions around the pulmonary veins. So now, with this device, we have the best of both worlds of RF and of cryo. We have flexibility, we have choice, we have lots of options and control, and we also have the speed that the 1st generation laser balloon was lacking. To show you that, you can sit back and relax and watch this video of the 4 pulmonary vein isolation that I put here in the left top corner of the screen. It's a real-time isolation. It will take 3 minutes for all veins to be isolated, and the blinking light will go around automatically. You just have to steer it a little. And for the ones that like to indulge in numbers, I'll show you what has changed in between the 1st generation laser balloon and the X3. First of all, with the first generation laser, our treatment time of a vein was around 20 minutes. That means inflating the balloon, positioning, performing the ablation, and then deflating the balloon. With X3, and these are our first 100 procedures, this time has gone down to 8 minutes, and most of the times now we have 5 to 6 minutes treatment time per vein, and an ablation time that is somewhere in between 180 and 300 seconds at a time. It did not change our first pass and acute PV isolation success. As you can see, it's around 90 to 100%, but procedure times were halved. Fluoro time is also half, so procedures went a lot faster and with a lot less radiation. Now we still have these learning curves, even with X3, and even though we have performed lots of ablations with the first generations of laser balloons, you can see that in the first 150 X3 cases compared to the total of 244 X3 cases that we analyzed up until now, procedure times have gone down, fluoro time has gone down, acute PV and first pass isolation have gone up, and recurrences are roughly the same, but you can see here that recurrences of AF without PV reconnection, this proportion has gone up from 50 to 62%. You can see that we're already halfway the ablation of the vein, almost finished. So I'll show you our 1-year results with this X3 laser balloon in our center, which is really excellent, I think. At 1 year, and all of those 244 analyzed patients reached a follow-up of 1 year, we had 91% of recurrence of paroxysmal and 86% of recurrence of persistent atrial fibrillation. So at 1 year, these are very nice results. And again, I will show you this in this effectiveness bar. As you can see here, for our center, it's the first time with any device that we have more than 90% success of freedom of paroxysmal AF at 1 year follow-up. So this is really nice. Now, I told you we want more than an effective procedure, we want an efficient procedure. And that's something that Boris Schmidt and Peter Noortse already showed in this X3 pivotal study that came out earlier this year. You see that procedure times were really shorter, ablation time is shorter, fluoroscopy time is tremendously shorter, and the effectiveness of the procedure went up. Now, with our classical HearLight cohort, we had already a higher effectiveness, but as you can see, even with shorter procedure and fluoroscopy times to start with, you still can achieve extra results with the X3 device. You can see here, procedure time is also halved, fluoroscopy time is half, and the effectiveness is unchanged, so around 90% at 1 year. Now, for these we used a recurrence of atrial fibrillation. As you know, this is dependent on medication and the treatment the patient has at that time. So maybe it's more fair to look at redo procedures and to see whether all pulmonary veins are isolated at a redo procedure we do for AF recurrence. And as you can see here, during the years from 2003 up until 2018, this hasn't changed very much, even though some studies were using the second generation cryoballoon or RF ablation with contact force. You can still see that at a redo procedure, in the majority of patients, the pulmonary veins are not fully isolated. The only study that makes a difference is where they checked the close protocol, which is now promoted by Sense Webster over Europe, and where they control contact force and power and interlesion distance. And when you follow this protocol, you can achieve 62% of patients having all pulmonary veins isolated after when they do a redo procedure. But this is something that we match with our laser populations. You can see this bar here is from the first generation laser, and these are the bars from the X3 device. You can see that in the same range, 60 to 80% of all patients have 4 pulmonary veins isolated at a redo procedure for recurrence of AF. So that means that AF recurrence at this time no longer implies PV reconnection, and in our center we are always prepared to perform a substrate ablation in those redo procedures. We also think that the success of the X3 procedure in Hasselt is dependent on some other factors. First of all, the use of rotational angiography, where we make a contrast injection into the left atrium and we superimpose the image we get on the fluoroscopy, so we can very easily maneuver the balloon in all pulmonary veins. We can estimate the position of the balloon in respect to the pulmonary vein ostium, and this helps tremendously in balloon positioning. And this is something that we really take care of. We want this image of contact of 360 degrees all around. This means with the X3 that you can start your ablation, you just go around in one circle and you close it, and you are sure that you made a continuous lesion with no gaps. Whether if you would start with this image, and this is from the same vein, you can see that we have no good contact at the superior portions of this vein. And this means that if we would perform an ablation and we get here, then we have to maneuver the device, we have to turn, we have to torque in order to get better contact here. And that means that possibly we have to stop ablation for some time, or we are not really sure that we have a continuous circle at the same level of the vein. So I'm sure this helps to have a nice 360-degree contact. And the third factor, I think that tells something about success, is the experience of the operator. Of course, we are an experienced center in laser procedures. We did almost 850 in total, with nearly 350 X3 procedures up until now. We only analyzed 244 of them that had a 1-year follow-up. But you can see there was a discrepancy between the number of cases that were done for each operator that performs these procedures in our center. And you can see that the operator with the most experience had the shortest procedure times, the shortest fluoro times. He had higher acute and first pass PV isolation. And although recurrences are the same, you can see that the proportion of recurrences without PV reconnection is much higher in an experienced operator. So to conclude my talk, there are some techniques available to do a PVI. First of all, we have radiofrequency ablation. It has a quite good effectiveness, but we all know this is very operator dependent and center dependent. Procedures tend to last a little longer, and they are not really cheap. And I don't talk about materials, but we have the cost of the training. If you want to do a good RF ablation, then you need at least 2 to 3 years of fellowship in order to ablate yourself in a good manner. And you need someone to support you who is behind the console, whether a skilled nurse or someone from the company. So this is costly. Cryoablation is easier and cheaper. It's also faster, but we lack a little long-term results. And also the first-year results do not get higher than 80% in most of the studies. And we have some issues with disadvantages like anatomical problems with common ostia, so you have to do pre-procedural imaging, and you have phrenic nerve palsies even in experienced centers up until 20%, albeit most of the times reversible. But you see, laser balloon ticks all these boxes. It's easy, it's cheap, it's fast, you can learn it in like 15 to 20 procedures. We have a great effectiveness, as I've showed you, and we have a low burden of adverse events. In our series, we have 0.8% of phrenic nerve palsy, and they were all transient. So I know there are some very interesting techniques that are emerging in the future. I think of pulsed field ablation, but for now, I think laser balloon ablation has shown a great efficiency, and it's certainly a technique that will last and that will stay with us. And I think some of my colleagues and even the chair of this session will agree. You see Dr. Kenigsberg, he did in December 2020 his 100th HearLight X3 ablation. He needed 1 hour skin to skin, 4 minutes of fluoro time, 100% in the rapid single shot mode. And Dr. Huang, he successfully completed his 80th laser case in March this year. On Twitter, he called it elegant, effective, and fast. And this is an interesting story. I did a proctoring case in a hospital in Belgium, and we had 2 very large common ostia. It would have been a disaster to ablate those with the cryo balloon. But with the laser balloon, we were able to occlude both of the ostia. We needed 6 minutes of lasering time in total, 25 minutes of left atrial dwelling time, and a 32-minute procedure. And I can tell you, this kind of procedure really lightens my day. I thank you very much.
Thank you very much, Dr. Koopman. We'll go back to the beginning and try again with Dr. Shiro Nakahara, Associate Professor of Medicine in Tokyo Medical University, Saitama Medical Center in Japan. His title again is Discrete Antral Lesions from Pulmonary Vein Isolation Using the HearLight Endoscopic Ablation System.
Thank you, Chairman. I will be giving a talk today entitled Discrete Antral Lesions from Pulmonary Vein Isolation Using the HearLight Endoscopic Ablation System. I have no COI. Isolated areas after laser balloon ablation have been reported to be smaller than those after cryo balloon ablation. However, When the laser balloon is inflated to maximum pressure, its size and compliance may allow visualization of a wider range of the pulmonary vein antrum. Larger-sized laser balloons have the potential to create a wider isolation area and may also prevent PV stenosis in the remote phase. The aim of this study was to investigate the clinical utility and the safety of the laser balloon ablation with larger balloon sizes. This study was a retrospective and single-center study. We applied this approach in 30 consecutive patients undergoing laser balloon ablation for paroxysmal or early persistent AF. In Japan, only the first generation HeartLight catheter is approved for insurance. For this reason, we use the HeartLight in all cases. This is our protocol. The upper PVs were occluded with balloon sizes of 5 to 8, and the lower PVs with balloon sizes of 3 to 7, and the laser ablation for PPI was performed. During the lesion formation, a contiguous lesion was created on the proximal side of the PV osseum as far as possible, with an overlap of 50% and a maximum power of 12 watt for 20 seconds. After the isolation of the 4 PVs, additional of the distinct antral ablation was performed, both bilateral, and the balloon size was increased from 8 to 9. Here is a specific lesion set. PV osseal line was indicated by the blue line, and the distinct antral lesion set is indicated by the red line. The distinct lines started from the bilateral upper PV roof and connected to the bilateral lower PV ablation lines on the posterior wall of the left atrium. The actual point-by-point laser ablation lesion is shown in the right panel. After the ablation, a 3D map was made in all cases. The isolated surface area, ISA, was defined as a ratio of the isolated area to the total surface area of the antrum and the posterior wall of the left atrium. In the results, this is the clinical characteristics of this study. Mean age was 65, about a quarter were female, 93% was paroxysmal AF, left atrial diameter was 39 mm, were included in this study. Regarding the acute success rate, the percentage of the PVs that were reconnected by the end of the 30-minute waiting period was 1.6%, 2 of 120. Actual balloon size for clinical use are shown below. Left superior PV osseum was 7.2, left superior PV antrum was 9, inferior was 5, right superior was 7.5, right superior antrum was 9.0, right inferior PV was 4.7. An interesting finding of this study was that during the creation of the distinct lesion set, the simultaneous visualization of the upper and lower PVs was common. The percentage of a simultaneous visualization of the upper and lower PV was 33% on the right side and 30% on the left side. In this case, as you see, wide antral lesion of the right side PV was confirmed, and we could ablate this line like this. Here is a typical example of a voltage map after the laser ablation. This case shows an extensive antrum isolation, and its ISA was 56%. In this case, roof block was coincidentally formed, and its ISA was 73%. And also in this case, the posterior wall was also coincidentally isolated due to the spatial proximity of the right and left PB ostia. In a total of 30 cases, the median ISL was 55%. All patients underwent a follow-up CT to confirm the remote PV stenosis. None of the patients had more than a 50% severe stenosis. We assume that the larger balloon size allowed for a more proximal ablation. This is a typical example of a moderate stenosis of a left superior PV, showing a 25% narrowing of the PV diameter from 16 mm to 12 mm. The patient has been asymptomatic. In addition, there were no esophagus-related complications. The outcome was also very good, with only one recurrence under an off-drug status at an average follow-up of 14 months. This is a summary. Our distinct antral lesion set, using a larger balloon size, yielded an extensive pulmonary vein antrum isolation. Although we used the first generation balloon, we succeeded in visualizing the upper and lower PVs with a relatively high probability and were able to apply the energy to a more proximal side. Few remote PV stenosis and no symptomatic esophagus-related complications confirmed the safety of the procedure. Future investigation of this approach using the X3 model is warranted. This is conclusion. Thank you very much for your attention.
Thank you very much, Dr. Nakahara.
Thank you.
Because of the technical issues at the beginning, we were awarded 5 more minutes for Q&A, which we'll take now. I think the first question, Dr. Huang, you have a question.
This is actually an earlier question for Atul regarding his presentation. We had a question about his RF duration and times during his cases, because that wasn't mentioned in the presentation, typically.
So
Go ahead.
Hi, this is Atul here. So this was my presentation was for my X3, where the average time for my RF, which have been only purely RF for over a decade, has been anywhere from about 150 to 175, maybe 180 minutes. That's the average time, versus close to now less than 100 minutes now for the XP3.
Thank you.
We'll now take some audience questions that I got through the app. First question I'll pose to Dr. Huang, and if anyone else wants to answer, I'd be apt to hear your answer as well. Are you seeing less or more atrial attacks or left atrial flutters with the laser balloon than with other modalities that you are using or have used?
That's a very good question, and we do have the registry data, and I apologize, I front-loaded the presentation. So, in the overall group, I think there was a trend toward less ATAC or flutter. In the paroxysmal AF group, there was not a difference between the occurrence of atrial flutter or atypical tachycardias, but there was a significant difference in the persistent group. We don't know if it's the lesion set or the type of substrates, but because patient populations were similar, it seems like it could be in relation to the modality and the way lesions are delivered.
The next question is for Dr. Koopman. Do we have that ability? Dr. Koopman, the question is, what percentage of the time when you ablate can you use the rapid mode solely?
Oh, that's a very good question. I think nowadays, when I do an ablation, in like 3/4 of the time, I can use rapid mode only and do a full circular ablation. And then I think an additional 10 to 15% I can do all in rapid mode. So most of the times I don't need the manual modes, but I have to say that in almost all cases, I try to put one manual 12-watt lesion on the anterior carina of the left superior vein.
Thank you. Dr. Bhatia, is there a way that you can talk to us about what made you switch to the laser from prior modalities you've been using?
The same as the title of the talk is efficiency and the time saving and the ease of use. I used very little cryo. I was only a purely RF doc for many, many years, and it made me switch to try. I never tried any other laser balloon. I was initiated straight on the XP3. And fortunately, as Dr. Koopman said, that in my experience too, what counts is the efficacy and time. It's been very efficient, and the learning curve has been very, very, easy. And the time for my last procedure have gone down significantly in less than an hour. As also the fact that my primary mode is the rapid mode, which I use predominantly with very good ease. And they use some manual lesions along the carina, but by and large, it's all rapid. And that was the major reason to switch. And I have not done a single RF case ever since.
Thank you. Dr. Nakahara wants to present a couple more slides, I believe.
Oh, okay. I will share.
Can we get that?
Can you see that?
Yes.
Thank you, Dr. Rivera. So it is just before 1 a.m. in Japan. So I would like to present a case that I performed just a few hours ago. I'm going to this is the image of antler shot on the right side. The HearLight balloon with maximum size was able to occlude both right upper and lower PVs. And antler contact confirmed with direct visualization of wide antler region sets. See? And then the left side also shows the size 9 balloon visualizing the left antler and delivering the laser energy to the more antrum side. See? So as you can see here, we have been able to create a worker region with the roof block. We are sorry that we are not able to present the X3 case today. As I mentioned earlier, the X3 will be available in Japan just next month, so we are very excited about the possibility of creating more enlarged region with the Excalibur balloon with rapid mode. Thank you.
Dr. Huang has a question for you before you depart.
Mm-hmm.
Two quick questions. At your institution, do you use the ICE catheter to visualize the balloon relative to the left atrial body? And when you do have the balloon larger, because it is the first generation device, is there still good stability with the balloon? In that image that you showed, there was very good stability.
Mm-hmm.
I can repeat if
yeah, basically, yeah, we often use the ICE images, yeah.
And that helps you to know that you're antral as opposed to in a vein with complex anatomy. So that's very useful.
Mm-hmm. Yeah, it was very useful. I agree with you.
In the interest of time, I'd like to thank all of you in the audience for attending. I'd also like to thank our esteemed international audience from literally all over the world for presenting their experience with the HearLight laser balloon. Have a great day. Thank you.
Thanks.
Thank you.